The United Leukodystrophy Foundation presents ALD, presented by Dr. Gerald Raymond, Dr. Troy Lund, and Dr. Florian Eichler.
Okay, good morning, everyone. I'm Dr. Raymond, and then I'm going to be doing an introduction of ALD, followed by my colleagues, Dr. Lund and Dr. Eichler, who are going to be discussing treatment for cerebral ALD. Just to be clear, adrenal leukodystrophy is one of the peroxisomal disorders. It's actually the most common peroxisomal disorder. It falls into this group we refer to as single peroxisomal protein disorders. Adrenal leukodystrophy is an X-linked disorder. It's located at XQ28. It has an incidence of about 1 in 17,000 with all the races affected. It's due to changes in the peroxisomal ATPase binding cassette protein, which results in defective peroxisomal beta oxidation and the accumulation of these unusual compounds called very long-chain fatty acids. And while they accumulate in all the tissues of the body, they predominantly affect the nervous system, adrenal cortex, and Leydig cells of the testes. And those are the organ systems we're going to focus on. ABCD1 is a gene that's about 20 kb long. It's a kind of small to average gene. It has about 10 exons. But one of the more interesting things that if you get DNA diagnostics for this, you're going to find a lot of different kinds of variations or mutations. And so we see all kinds of these variants. And so it's not unlikely that your family, if you have ALD, has got a unique variation. One of the more fascinating things about ALD is that it has several different presentations. We'll talk about them briefly. There's an asymptomatic form, which everyone has at birth, and we'll discuss it a little bit more later on. There's an adrenal insufficiency or primary adrenal insufficiency, sometimes referred to as Addison's disease. There's a cerebral form, which we're going to talk a little bit more in depth with and have our later speakers talk about treatment for. And then there's adrenal myeloneuropathy. If you have adrenal myeloneuropathy, you shouldn't be in this session. It's the following session, but you just stick with us here. Childhood adrenal leukodystrophy is what most people think of when they think of adrenal leukodystrophy. These are boys with initially normal development, and then somewhere between 4 to 10 years of age, they begin having subtle neurologic issues. And then unfortunately, it progresses really very rapidly, with many boys dying within 1 to 2 years following the diagnosis. Adrenal insufficiency we see in about 85% of individuals. Adrenal myeloneuropathy is an adult form of the condition with a mean age of about 25, with difficulties walking, sensory involvement, bladder dysfunction, and this typically has a gradual progression, although some men will still develop cerebral disease. We think of it as an axonal disease without the inflammatory changes we see in the cerebral forms. Primary adrenal insufficiency or Addison's disease is exactly that. It's primary adrenal dysfunction. It can present acutely or chronically. It can result in low blood sugars, difficulty fighting infection, dehydration, and an increase in pigment. It's rarely seen that we see the low sodium, high potassium, which is kind of classic because the mineralocorticoids are not as affected. However, it's a leading cause of adrenal insufficiency in men. And the majority will develop neurologic manifestations at some point. So we don't think of this as some sort of carve out in terms of presentation. This asymptomatic phenotype is what I'm going to focus on for a few more slides because these are boys with normal brain MRI. They're diagnosed by plasma very long chain fatty acids because someone else in the family is known to have ALD. Previously, it wasn't identifiable in the past, but as we'll talk about, it's typically the most common phenotype because it is what everyone is born with if they're going to have ALD. Just so that we're not forgetting them, women have symptoms. About 20 to 50% of women who are carriers will develop some symptoms with age. It predominantly looks like AMN, and some individuals, some groups are really feeling very strongly that we shouldn't be calling them symptomatic heterozygotes, but actually affected individuals. They have spastic paraparesis, dysesthesias, and bladder and bowel symptoms. And certainly is a function of age. And it's very, very rare that we see cerebral or adrenal disease. Just to be clear, the fact that you have the change in your gene does not tell us what form of the condition you're going to have. And many families have both individuals with cerebral disease as well as AMN. We make a diagnosis by the elevation of very long chain fatty acids, and we can do it in blood or tissues, doesn't really matter what. We know that women can give us a false negative rate, but we use DNA diagnostics in those individuals. Our current ALD therapies are adrenal hormonal replacement, and that we should never overlook. Once you start it, you're on it. There's also people are looking at antioxidants. Bone marrow transplant or hematopoietic stem cell transplant is what Dr. Lund is going to be discussing. We use this in early cerebral disease. And Dr. Eichler is going to be discussing gene therapy. I want to just spend a few slides talking about newborn screening for XALD because I think this is the most major development presently going on in diagnostics. So New York State started newborn screening, which is essentially taking blood from all newborns and looking for ALD in December of 2013. It's now on what we refer to as the Recommended Uniform Screening Panel, which made that list by February 20. And in this slide, it was about 14, 15 states are now screening for ALD. And so be expecting this to come to a state near you. Once we have a newborn who is confirmed to have X-linked adrenal leukodystrophy, it's important that you confirm it. We also obtain what's referred to as a pedigree or a family history. We're going to talk to you about what that diagnosis means for your newborn, and then begin surveillance and then intervene and treat as appropriate. Adrenal insufficiency, which is, again, Addison's disease, doesn't develop all at once, but it comes over time. And so we're now seeing individuals as young as 5 months. And so it's very important that individuals be seen by a pediatric endocrinologist in the first months of life, because we have seen a crisis in death as young as 22 months. Early cerebral disease is what we're looking for in terms of manifestations at which we can intervene with either gene therapy or bone marrow transplant. So the initial MRIs are always normal. We see early changes on MRI are characteristic of the disease, but these boys are clinically asymptomatic at that point. So they have a normal exam, normal neuropsych, normal school performance, and it progresses over months to years. And so what we see is this little change here, and this is the stage where BMT or gene therapy is now most effective. So once again, what we want is get the rest of that family history, because while we may have a boy with this disorder, he may have cousins, he may have other individuals who are at risk, and these are individuals we also need to assess and intervene in. So once again, it's an X-linked disorder, and it actually turns out it's one of the first on the newborn screening panel. Some states are also screening for Fabry, but that has not yet made the recommended uniform screening panel. We are going to identify other family members at risk. We're going to do very long chain fatty acid testing in all those males, and then ABCD1 targeted testing as appropriate. We're going to be doing ABCD1 testing in women greater or over the age of 18, depending on their reproductive risk. And then as appropriate for girls younger if they're being considered as potential donors for bone marrow transplant. It certainly clarifies a neurologic and endocrine diagnosis, although we are finding that 5 to 7% are new affected members of their family. I want to thank the ULF for allowing us to present this, and I'm going to turn this over to Dr. Lund.
All right, let me share my screen here. Application. All right, am I coming in okay? Can you hear me all right? Oh, yes. I was looking at the comments there. All right, well, thank you, Jerry, for that introduction. So I'm Dr. Troy Lund at the University of Minnesota. I'm a bone marrow transplant physician. I specialize in childhood cerebral adrenal leukodystrophy, though our clinic is very busy with actually the various forms of ALD, including AMN and adrenal insufficiency. What I'm going to focus on is the outcomes after transplant and some of our new ways to predict who's going to do well. I try to always present new things at this conference, or at least add to prior stories. And this is an example of a wrap-up of a bunch of the work that we've just completed and has been accepted for publication. So who's going to do well is the title of this. So as a reminder, cerebral ALD is really demyelination, and it's followed by inflammation. And the way that it's diagnosed, detected, is by MRI. And so I always like to show a picture of a normal MRI, which is on the left, and that's pulled from my favorite medical source, which is the internet. And then we have the not normal MRI, a 7-year-old child with demyelination in the rear of his head, as you can see by the white signal. Clearly that doesn't belong there and looks different than all the normal white and gray matter in the front of his brain. Now this is accompanied, when you get an MRI, we infuse a contrast agent called gadolinium, which is a heavy metal. And that metal breaches the blood-brain barrier when that barrier is open and inflamed. And so this is what we often call Garland ring enhancement. And it's characteristic of active cerebral ALD. And so this is what we're looking for to make the diagnosis of active cerebral ALD. Now, as we all know, and as I've said in many different talks, the complete mechanism of how this all happens is unknown. We believe that approximately up to 4 out of 10 boys with ALD will develop the cerebral form by age 18. And despite our studies for many years and the work in the Netherlands and in Boston, I don't know if any of us can predict which 4 boys that's going to be. And it even varies within families that harbor the same mutation. So as far as I can tell, it's really not predictable. We do know that the demyelination is mostly progressive. There are occasional rare cases where the disease may self-arrest, as was discussed earlier. But by and far, mostly it's a progressive disease. We know that steroids and immunosuppressants can only slow the destruction. This is often temporary in nature, and it works in some boys. I have tried a variety of all sorts of unique agents, many of them borrowed from the multiple sclerosis community, which really don't have much an effect on this demyelination process. We do know the blood-brain barrier is broken, as evidenced by that nice ring of gadolinium enhancement. And then thus far, today, the only way we know to arrest this disease is through a bone marrow transplant, which exists in 2 forms. There's the classic, somebody has donated their marrow, brother or sister, or an unrelated person. But then there's also gene therapy, which is in fact also a bone marrow transplant. So Florian will be talking more about the gene therapy. I'll focus more on the allo transplant. And so the data I'm going to show you is from a cohort of boys that we've been following, that we have a multitude of data points on, and is our most robust data set. The average age of the boys is around 8. Their MRI score, otherwise known as the LESS score, is somewhere around 9 with a broad range. You can see other characteristics and variables listed in the chart. Many went through a myeloblative transplant. Some went through what we call reduced intensity type transplant. The donor sources for this set of data come from the stem cells come from the umbilical cord blood, an unrelated donor, or a sibling donor. And once in a while, we might use a parent as a donor if we cannot understand, if we cannot have good matching. So, and then the cell doses are given here. So back to this gadolinium enhancement as shown on the left slide. Again, another boy, approximately 6 years of age, with this Garland ring of enhancement around his demyelination. This is an MRI image 10 days prior to transplant. And what is the goal of transplant? Well, it's to take this MRI and convert it to this MRI. And this is the same boy about a month after transplant. And you can see that inflammation is completely gone. And we call that ALD in remission. And so there's no further enhancement. And in our prior work, this enhancement seems to get extinguished and then really has no evidence of returning. So this is the whole goal of going through transplant when a boy has cerebral disease. Now, fundamentally, we'd like these boys to have this so-called gadolinium resolution, which is the term I'm going to use for this. I'll call it GAD resolution mostly, to have GAD resolution as fast as possible. Like any disease we treat with transplant, we'd like to send the disease into remission as quickly as we can. And in this case, since we use MRIs as our tool to detect disease, in our practice, the first MRI is 30 days after transplant. So that's kind of the baseline, or what I'm going to pin the study on is 30 days after transplant. Certainly, we'd like it to go faster, but logistically, we don't get MRIs, for example, every week after transplant. Now, I just put in this slide to give you an example of what the transplant process looks like. And this is cut right out of our protocol, and it's one of several protocols we use. It may not be as up to date as what we're currently doing, but it gives you an idea of what happens in a transplant. The transplant itself is on day 0. So our whole world is surrounding day 0, which is when we infuse the cell product, whether it's gene therapy or whether it's a bone marrow transplant. Prior to day 0, we use several different drugs. We use anti-thymocyte globulin to wipe out the child's T cells. And then most importantly, we use chemotherapy. We use busulfan and we use fludarabine. And these are examples of when we give it. In this case, both of these are once a day, 5 days prior to transplant, 4, 3, 2. And these are the doses. And the rationale behind the chemotherapy comes from the leukemia and lymphoma field, where transplant has lots and lots of history, is that we don't want to eradicate a leukemia, but we do want to eradicate that old immune system in the child. And so the only way we knew to do that is with high doses of chemotherapy. And I should add that this chemotherapy is the same whether you're getting gene therapy or getting an unrelated donor transplant or related donor transplant. So it's the same drugs, and they come with their share of side effects as well. But fundamentally, this is what it looks like just prior to transplant. As you've received these high doses of chemotherapy, most kids do really well. There's a rest day in this protocol just prior to the transplant, and then we infuse the cells. And then we count up. So the day after transplant's +1, up to +7, +30. And once you get years away, it's day +365, etc. So that's how our whole world works, is on this transplant paradigm. And for allo transplants, there are anti-rejection drugs given at the same time, like cyclosporin or steroids or a drug called MMF. These types of drugs are required for the transplant not to be rejected, or the transplant not to reject the body. These drugs are not given in the setting of gene therapy because you're using the child's own cells and they're not required. So I just thought I'd give you a snapshot into the roadmap of transplants so you can have an idea of how it all works. But we use this for lots of different protocols and lots of different diseases. Fundamentally, it's kind of the same layout. You have an arrow going to the right, you have the drugs you're going to use and what you're going to do. Okay, let's go back to who's going to do well after transplant. And so we've spent a lot of time trying to find biomarkers, either imaging biomarkers or blood biomarkers or spinal fluid biomarkers that would predict who's going to do well, who's going to progress through transplant, and who's going to have arrest the disease. And it turns out that this is really, really difficult. Now, this is an example of an imaging biomarker we call the gadolinium intensity score. And again, gadolinium is the heavy metal that breaches the blood-brain barrier and shows you if you have active cerebral disease. A few years ago, we developed and published this score. It's a very crude system. It's 0 for no intensity or no enhancement, which essentially means you don't have active disease. And then it's 1, 2, and 3 is the scoring system. And basically the 1 is you're comparing the brightness of the gadolinium shown by the arrows here to an internal control called the choroid plexus, which sit in the ventricles and produce all the CSF for your brain. And that's automatically bright on MRI. And so we use that 1 if the gadolinium is dimmer than the choroid plexus. We use the number 2 if the gadolinium is the same brightness. The choroid plexus is indicated by the little white arrowheads, by the way. So 2, it's the same brightness. And then 3, you can see this large amount of gadolinium here by the arrow, is when the gadolinium is brighter than the choroid plexus, which is shown here. So albeit this is not the world's best scoring system, but it did correlate to disease progression in our initial publication, and again added to our set of biomarkers in which we hope we'd get better at predicting disease outcomes. So what I did was group the patients that I showed you in the first graph by gadolinium intensity score, 1, 2, and 3. And then I asked the question, what was the percent of boys that got rid of that gadolinium on the first MRI, which is 30 days after transplant? And so for the remaining of the talk, I'm going to always say early GAD resolution, and what I mean by early is the first MRI 30 days after transplant. And it turns out the lower the score, so the dimmer the gadolinium, the higher the percentage that the boy would resolve their gadolinium early. So 65% for GISO1, 43% for GISO2, and if you had really bright gadolinium, only 22%. And the data was just barely significant at a p-value of 0.04. And so intuitively, I guess this made sense, because perhaps the more gadolinium that crossed the blood-brain barrier, the more open it was, the more inflammation you have, the more damage that was ongoing, and the harder it would be to make it go away. But prior to the development of this data, even though it was intuitive, we never really had shown it using numbers. So this is our first foray into that. But it's not very robust. You can see the p-value just barely makes it significant. Was there a better way to do it? Is what I asked. And so then we thought about measuring gadolinium volume. So this arrow, the arrows here on the left show gadolinium enhancement, and you can actually draw a box around this, and you can measure that box and generate an area to measure how much gadolinium there is. And as many of you know, the MRI is done in slices through the brain. So all the images stack on top of each other. And if you do this on the upper images and the lower images, you can actually compute a volume of gadolinium, because the brain and the gadolinium are not just in 2 dimensions, they're in 3 dimensions. And so this is what we did, is we in fact circumscribe all the gadolinium signal on all the MRIs of all of these patients in all of the cuts. And then we calculated the volume of that enhancement, and that generated us a number, generally in cubic centimeters. I will remind you, again, in this MRI, a month after transplant, our goal is to have this gadolinium enhanced area be completely gadolinium negative, or for the child to, or what we call have gadolinium resolution. So this is the data from all the boys. This is the gadolinium volume in cubic centimeters. these are the volumes, and this is the distribution. You can see most of the volumes are between 0 and 5 cubic centimeters. The data is highly skewed towards this lower region just because that's how the data fell out. When you're dealing with data, it's better to have a normalized distribution. So kind of what you want to see is a kind of a nice hump in your distribution of data with the extremes having less numbers. And so what you can do is take the log of that data to transform it. It doesn't change the fundamental data, but it does distribute it better. And these graphs just show an improved distribution, which is what I'm focusing on the rest of the talk, is really the logarithm of the GAD volume, not the GAD volume. You can see there's some outliers here at each end. We've decided to keep in the outliers just because these are real data points from real patients, and I generally try not to exclude any outliers at all. So we left them in despite them not falling on our nice line. So when we test our idea about whether or not the gadolinium volume predicts early GAD resolution, these are the kind of data we see. These are the p-values of the statistical tests. So I already showed you that the CAD intensity score, the GIS by itself, had this p-value, which is barely significant. When I looked at the volume of enhancement on the second line, we got a pretty robust p-value here at 0.0087. So it's fairly significant. I actually tried something where I took the volume I generated and multiplied it by that intensity score, which gave me a very unique number, and used that to try to predict who was going to resolve their gadolinium. And that gave us a pretty decent p-value, but it wasn't as robust as this line here. It's when you take the log of the volume of enhancement and use that to predict who's going to resolve their gadolinium at 30 days, you get the most highly significant value at p of 0.0003. And so this is where we focus the rest of the analysis. It's not that these are not significant, because they are, but this gave us the most robust significance in the analysis. And so that's what we stuck with, was log volume of enhancement. And of course, you can convert log, you can convert cubic centimeters, you can take the log or the anti-log and go back and forth. So this is some of the raw data. This looks at boys that got rid of their gadolinium at 30 days after transplant. Yes. Those that had gadolinium still, no. And then we just looked at the log GAD volume. And it turns out that the less volume of gadolinium you had, the better your odds were to make that gadolinium go away at 30 days post-transplant. And so this is the first piece of data that suggested we were onto something. And again, just like in the table, the p-value is 0.0003, so pretty robust p-value. So the more of the gadolinium you had, the longer it took to go away, which again intuitively makes sense, but until this point, nobody has really demonstrated it numerically. Now, I did look at a whole bunch of other biomarkers that we've published over the years to see how they correlated with early GAD resolution, again, 30 days after transplant. I looked at the MRI score developed by Dan Less here at the University of Minnesota, and that measures the amount of brain damage prior to transplant on the MRI. And it goes from 0 to 34, basically. And these are the pre-transplant MRI scores. And so the lower the MRI score, the more likely you had gadolinium go away by day 30, and the higher the score, the less likely it was. And again, the less score doesn't actually take gadolinium into context. It's just the amount of demyelination that's occurring. So this was interesting, and it was significant with a p-value of 0.03. We had measured a marker of monocyte macrophage activation over the years called chitotrosidase. And we found that boys with more severe cerebral disease have higher levels of plasma chitotrosidase and also higher levels of CSF chitotrosidase. So I simply asked the question, what is the difference between the plasma chitotrosidase between the boys whose gadolinium went away quickly versus the boys whose gadolinium stuck around longer. And it turns out these boys had lower levels of plasma chitotrosidase. And again, that data, it just makes a significant cut at p-value 0.04. We can do the same assay in cerebrospinal fluid, and we get kind of the same result. Boys that had their gadolinium go away quickly had lower chitotrosidase with a p-value of 0.04 versus those whose gadolinium stuck around for a while. And then finally, we published last year that speed of engraftment or speed of your immune system recovery actually correlates to gadolinium resolution. And so we looked at immune system recovery in a way that I made a cutoff of 16 days after transplant. So those boys that recovered their immune system faster than 16 days are shown on the right, slower than 16 days are shown on the left. And then we looked at the percent with gadolinium resolution by day 30. And it turns out if you recover your immune system faster, the percentage of boys that resolve a gadolinium was about 50%. But if you recovered your immune system slower, it was only about a quarter, so 25%. So that speed of engraftment plays a role in gadolinium resolution, and that data is also significant. And some of this has already been published. So these are the types of pre-transplant and post-transplant variables that I looked at in the entire model. And then when we get down to concluding this, so these are the variables I looked at, as I've been telling you: log volume enhancement, gadolinium intensity score. I looked at donor status of the myeloid cells and the T cells. I looked at the pre-transplant MRI score, CSF protein, plasma chito, C26 level was looked at, CSF chito, the slower versus faster immune system or neutrophil recovery is what I'm referring to. I looked at the preparative regimen. And when I do statistics for all these different things, the ones in the yellow are the important ones that stand out and are statistically significant. And so this is great, but what you want to then do is a multivariate analysis and put all these variables into a model, and you ask the question, out of all these things, which of these variables turns out to stand by itself and is the most important thing? And when you do that, you see this. You see that, in fact, log of volume of gadolinium enhancement turns out to be the most important variable or most important factor in predicting early gadolinium resolution with a p-value of 0.016. The rest of these, their p-values kind of fall off, likely because they start canceling each other out because they're related. Gadolinium intensity score is related to the total protein score. It's related to chitotrosidase in the CSF, etc. Even the neutrophil recovery time falls out. So in multivariate analysis, which is a very robust and strong way to compare data, shows us that log volume enhancement actually is the central predictor of early gadolinium resolution. Again, intuitively, it all makes sense that the less gadolinium you have, maybe the faster it'll go away. But until now, numerically, nobody's really investigated it, at least not like this. So we thought this was very interesting and exciting. And then in our last point here, we did look at function of these boys. So we have a way to assess boys using the neurologic function score developed by Dr. Jerry Raymond. And it's really a dysfunctional score because you get points off for problems the boys have. So if you have a hearing problem, you have 1 point off. If you're blind, you have several points off. Field cuts, 1 point off. Walking difficulties give you a point. So all of us should be a score of 0. Your maximum score is 25, and you can imagine children that score that high are moribund. And then many kids are somewhere in the middle here, depending if they have a wheelchair, incontinence, etc. So I simply asked the question, every boy that we assess comes in at a certain NFS, and then at 1 year post-transplant, they often have a change in their NFS because they lose some ground, and we call that the delta NFS. Now, in a perfect world, I'd like that delta to be 0. So we'd like to have boys go home exactly the way they come in and not lose any neurologic function. It doesn't always happen, unfortunately, and so the boys, many of the boys do gain points. And so what I did was simply ask the question, if we look at the delta NFS, so how many points they gained from transplant to 1 year post-transplant, did that correlate to day 30 post-transplant GAD resolution? It turns out it did. The boys that gained the fewest points by 1 year post-transplant had the earliest resolution of their gadolinium. Many of them gained no points, which is fantastic. While those who had gadolinium stick around for a while actually started gaining points. 1 point, 2 point, 3, 4, 5. You can see some of them gain a lot of points here. It's not perfect. As you can see, some of the dots reside outside the boxes, but it did correlate quite well. And then one final analysis we did was just take the boys that had 0 to 1 gain in points. So they are the boys that showed the smallest amount of progression after 1 year after transplant. And that's what we call delta NFS 0 to 1. I then correlated day 30 post-transplant resolution to log GAD volume, and we were actually able to put a number on how much gadolinium you could have and still resolve by day 30, versus if you had higher amounts of gadolinium, you were less likely to resolve that gadolinium by day 30. And again, intuitively, this all makes sense, but this shows it numerically, and this data was highly significant. So the highlights of what I've shown you is that the blood-brain barrier is disrupted in cerebral ALD, and this disruption is indicated by gadolinium enhancement. Gadolinium can be quantified on the pre-transplant MRI, and gadolinium volume pre-transplant actually correlates to timing of gadolinium resolution after transplant. So again, that earliest 30-day post-transplant time point. And that early gadolinium resolution after transplant is associated with less neurologic progression at 1 year post-transplant. So, and thank you to all the support we've had to allow these analyses to take place, from Knockout ALD, from Oliver's Army. Thank you to all of the families and all the co-authors that helped me investigate this process. And now, do I stop sharing? Okay.
Hello, can everybody hear me? Okay. Great. Share screen. Great. Can everybody hear me? Okay. Thanks so much, Dr. Raymond and Troy Lund, for providing this nice overview. And in many ways, what I'll be talking about builds very nicely on the bone marrow transplantation experience and the work that Troy showed on blood-brain barrier disruption. I will provide an update on gene therapy in X-linked adrenal leukodystrophy. Next slide, please. So just by way of disclosures, to mention that compared to the prior slide where I showed an old image of Massachusetts General Hospital, that was at the time still an isolated academic institution, we now live in a new world that encompasses a big landscape of biotechnology, and my disclosures here are evidence of the many interactions with industry that I have. These bring opportunities to move new treatments forward, but also pose challenges around transparency and disclosure. And so just to mention here that I am PI of the ex vivo lentiviral gene therapy trial for cerebral ALD, sponsored by Bluebird Bio, and I'm also founder of Swan Biotherapeutics. Next slide. That having been said, I think the recent weeks and months have again emphasized that, beyond looking at the opportunities around new technology and boutique medicine, we need to keep in mind whether treatments are rolling out for patients across the population and are not similar to other things that we are seeing in our world today, discriminating by socioeconomic status or by ethnicity. And here a picture showing that our hospital has been very much shaken also by not just the COVID-19 crisis, but also the racial inequality that we have heard of in the past few weeks and months. And just to emphasize here that racism in medicine isn't an abstract notion, but it's happening all around us every day. And it's a big challenge for us to think about how can we move forward with some of these pioneering modalities in a way that gives equal access to everybody. Next slide. So I will briefly talk about ex vivo lentiviral gene therapy in cerebral ALD, and I think that builds nicely upon what Dr. Lund just mentioned in terms of the ability here for bone marrow cells to enter the brain and halt the progression in children with cerebral ALD. I will then pivot towards in vivo AAV-mediated gene therapy in AMN, the spinal cord disease of adrenal leukodystrophy, as mentioned by Dr. Raymond. And I will close with some general points around challenges and opportunities for gene therapy in neurology overall. Next slide. So the history of gene therapy has been one of much excitement lately, but it must be remembered that this history goes back many decades and has not always been a history where everything was moving forward and there were many bumps along the road. But just to point out that this has been a long time in the making, both with the discovery of adeno-associated viruses, the first human retroviral cell-based applications in the 1990s, and then those of adeno-associated virus applications in humans shortly thereafter. More recently, we have seen first approvals of gene therapy by FDA, both nusinersen for spinal muscular atrophy, as well as Zolgensma for SMA as well. And we are seeing that FDA is increasingly aware of the potential of gene therapy and is providing more guidance to how to arrive at regulatory approval for some of these desperate and degenerative neurological diseases. Next slide. So the approaches to gene therapy really fall into two categories. On the one hand, in vivo gene therapy, which is an AAV-mediated gene therapy for the most part, with direct delivery to the target organ or the compartment of the nervous system. You're delivering the virus carrying the faulty transgene in its corrected form, and this goes either to liver or to brain or spinal cord. And on the other hand, ex vivo gene therapy, which is usually lentivirus mediated and is requiring here a cell-based delivery modality. That means we are delivering outside of the body, ex vivo, the lentiviral vector carrying the gene onto cells that are then infused into the body. Next. So here to demonstrate the different routes that in vivo AAV-mediated gene delivery has taken. Usually AAV is delivered locally into the brain directly, as shown here on the far left, or intrathecally into the spinal fluid, in some cases intravenously if you want more systemic coverage and need the liver also delivered to. Many diseases in the neurological space have benefited from an understanding of the different brain regions vulnerable, such as Parkinson's or Huntington's disease, and also from the many years of efforts in lysosomal storage diseases where we know cross-correction is possible. Right. Ex vivo gene therapy, on the other hand, usually uses hematopoietic stem cells that are transfected with a lentiviral vector. And these cells usually populate the mononuclear phagocytic cell lineage. These are usually monocytes that will travel up into the brain and renew the microglial compartment expressing normal protein. What are these microglia? We then think of these microglia as the traffic cops in the brain. They are the first responders to any site of injury, and they also play a crucial role in cerebral ALD, where we know they are the first cell types that are known to start dying in a zonal distribution, and quite dramatically so. Next slide. So we've really, over the past few years, implementing ex vivo gene therapy for cerebral ALD, seen a dramatic change occur, and it wouldn't have occurred without all the decades of experience with bone marrow transplantation that Troy Lund mentioned. When I started my clinic, most of the boys who came to my clinic 15 years ago arrived in wheelchairs, were quite devastated, and at death's door. While I would say the vast majority of boys I now see in clinic are highly functional and participating in day-to-day activities such as other peers their age. And you can see here on the right is a boy who's playing soccer, whose parents sent me this picture in the fall, and he was the first boy treated with ex vivo lentiviral gene therapy, and it was a delight to see that. Next. So just briefly to summarize, the first publication and study in childhood cerebral ALD using ex vivo lentiviral gene therapy, to remind everyone the criteria for implementing ex vivo gene therapy is similar to cerebral ALD, BMT use. So you have to have gadolinium enhancement, and we look for changes in less score and gadolinium enhancement. And of course, we want to avoid any insertional mutagenesis. Next slide, please. So briefly, what do? We identify boys with cerebral ALD. We harvest their bone marrow cells. We transfect them, these cells that are CD34 positive with a lentiviral vector carrying a normal copy of the transgene. We give a brief amount of myeloablation of busulfan cyclophosphamide, and then we transfuse these cells back to the boys, and we follow them for a 2-year period. And it's important to note that this is identical to what happens in conventional bone marrow transplantation, with the exception that these are cells from the boys themselves. So we're avoiding a lot of the engraftment problems in graft versus host. Next slide, please. So we have treated so far 32 boys, about half of them here in Boston. These boys were all boys who had a low, less score and were asymptomatic at the time of treatment. And so it's important to remember that, again, we think this is far more effective in the early stages of cerebral ALD, and that faces challenges thereafter. Next slide. The vast majority of the boys did exceedingly well. You can see here the neurologic function scale that Troy Lund mentioned earlier. There was one boy who at the time of enrollment was already progressing very quickly and succumbed to disease progression. And there were two other boys who dropped out of the study after they had some contrast enhancement recur. But the vast majority of the boys remained either asymptomatic or minimally symptomatic, and quite the contrast to untreated patients in the historical control group shown on the right. Next. Contrast enhancement resolved in the vast majority of the cases, as you can see here in the bottom graph, and this is markedly different from what you would see in the untreated condition, where there's usually a garland of contrast enhancement. And concurrently with that, there was a stabilization of the lesion, again, very different from the untreated condition. Next slide. Did we get the gene in, and was protein expressed? And you can see vector copy number in peripheral blood up to the last follow-up shown here on the left. And on the right, you can see that ALD protein expression was found in about 20% of the CD14 positive cells, proving here that we were expressing ALD protein after delivering the gene into the bone marrow compartment. Next. We have been fretting a lot over the amount of contrast enhancement that recurs after ex vivo lentiviral gene therapy. At 6 months, usually contrast enhancement disappears, but in many cases it does recur, but it usually just flickers, and it's much fainter than what we see in the untreated condition. Okay, next slide. Just to highlight here briefly, ex vivo gene therapy has significant advantages in that we don't see engraftment problems or graft versus host disease, but we do have downsides here that occur because of adverse events due to myeloablation. And we also know that adrenal myeloneuropathy can occur after bone marrow transplantation. And so we think we need a different approach that requires broad delivery to the entire spinal cord and peripheral nerve. And I will just, for the sake of time, just highlight the new modality that we're employing and then open up to questions. Next slide, please. So we, based on the work by Brian Casper and Jerry Mendel, really used the modality of AAV-mediated gene therapy to target dorsal ganglion, astrocytes, microglia, and endothelial cells. And we did this for the simple reason that this treatment in spinal muscular atrophy targets a nearby structure, the lower motor neuron, and was very effective in treating the disease in children affected by spinal muscular atrophy. And so knowing that here the dorsal columns and the corticospinal tract is in immediate vicinity, we were very encouraged and have put forward a program based on this work. Next slide. Just here to, in my last slide, highlight that the spinal cord can be targeted by AAV9-mediated gene delivery. And we've published now in multiple papers that we can, using an AAV9-mediated approach where we package human ABCD1 into this vector, deliver the construct to the relevant cell types, and not only get it into those cell types that are important to ALD pathology, but also into the right compartment, namely the peroxisome. And we know that because we looked at co-localization with the peroxisome and also being able to show lowering of very long chain fatty acids, both in vitro and in vivo. So I just want to stop there for the sake of time and just mention that there are complementary approaches in gene therapy, and that these will really probably in the future be used in conjunction with each other, as we know not one size fits all, and that, as Dr. Raymond earlier mentioned, adrenal leukodystrophy has multiple different phenotypes. Thank you.
Wonderful. Thank you to all of our presenters this morning. We do have one question that's come in. We have about 5 minutes left in the session. So if any of our people that are watching on YouTube want to go ahead and start typing your questions into chat, I'll pass them along to the presenters and we can answer any questions that you have at the end of the session here. So the question that we have from Luann, she says, thank you, doctors. Please review in a brain MRI. Did I hear correctly that the white matter enhancement actually shows up as a dark black? Can you show us one and point again?
I don't know that any of us can pull up our slides, but no, it doesn't show up as dark black. It shows up as a ring of bright white.
Okay. And then, so gene therapy could be used for AMN in the future?
That is currently work in progress. I think we see some proof of concept in other diseases such as spinal muscular atrophy, giant axonal neuropathy, and other diseases that affect spinal cord and peripheral nerves, but a lot of work is still needed.
Okay. Next question is, what is the deciding factor between bone marrow transplant and gene therapy?
Troy, you want to take that? Otherwise, I can take a stab and you can chime in.
Yeah.
I think availability of donor is, I think, a very important one. And experienced transplant centers like Minnesota can very quickly find well-suited donors. But I think if there is no donor available, then there might be an argument to use gene therapy and the cells of the boys themselves. Troy?
Yeah, I think that's very accurate. Our favorite type of transplant is from a brother or sister into a brother or sister. Matched sibling has the least amount of side effects and is the less riskiest. But as we try to match people to stem cell sources, when the matching goes down, the side effects and the risk of GVH go up. And so we try to weigh that degree of matching against the options such as gene therapy, which you don't have a problem with that.
Right. Okay. Next question is, how far away are we from the first trial for gene therapy for AMN?
So it is hard to say for sure. None of us have a magic glass, but the plans are to be in humans within the next 2 to 3 years, and very much depends on what we are all collectively learning about the safety and efficacy of gene therapy. Because clearly, if we want to move forward, we want to do that safely and with the safety of patients in mind.
Okay. And it looks like this might be the final question that we're able to take. When/what is the research connecting AI to ALD, particularly on the effectiveness of cortisol replacement on arresting the inflammation and thus disease progression of the brain and/or spine?
Gary?
So there is no correlation between the adrenal insufficiency and the development of cerebral or brain, any kind of CNS manifestations. The issue becomes in many brain inflammatory diseases, high-dose steroids have been used, multiple sclerosis and other inflammatory conditions. And so they've been tried. They may buy you a week, but they do, the effect doesn't last. Which gets to, it's probably a multi-immune system dysfunction rather than just a B-cell mediated inflammation. I think that's generally been what has been the concern.
Right. Even giving steroids into the cerebral spinal fluid does not give you a long-lasting effect. So.
All right, great. Thank you so much, Florian, Troy, and Gerald, Jerry, for being here with us today and taking the time to answer some questions. Thank you to everybody that joined us on the YouTube side and throughout the whole entire conference that we've had over the past 3 days. And hopefully we'll be seeing everyone in Chicago next year.
See you then.
See everybody again.
Bye now. Take care, everyone.